Director of Hospice and Palliative Care, and I'm thrilled to have this many people here. Plus, we have about 6 people who are here on GoToMeeting. And Diane Brazelton, who's our new marketing manager, is going to be videotaping it. We're going to post it on YouTube. So very exciting to have such a huge turnout. I was talking to Deb earlier. Steph Abel, where are you, Steph? And Deb McGarvey have been caring for a patient on palliative care for almost a year. And I was saying to Deb, it probably would have been a lot more helpful to all of us to have this presentation last spring. But we continue on both hospice and palliative care to care for other patients with ALS, and really thought that it would be a terrific topic to have Deb and Cindy come and present to all of us. So Deb Guntram and Cindy Gibson, who are both nurse practitioners in the Neuromuscular Disease Clinic at the Medical Center. So I'm going to turn it over to them, and thank you both so much for coming here this morning.
Thank you, Mary, and thank you all for coming and listening to us today. We are really excited to be here and to share with you our experience of working with people with ALS, or PALS, as we call them. And I'm wondering, first, a couple of things. Is everyone in the room nurses, or what other social work, speech,
OT,
chaplain,
OT,
aides, wonderful.
physical therapy.
Physical therapy, terrific, and we're going to come back to that, but it's important that we're all at the table because we are all participants in the care of ALS, so it's good to see everybody here. And I'm also wondering, how many of you have had ALS touch your personal life? So outside of caring for people within the work setting, has anybody known people with ALS? Yeah, me too. I'm actually caring for somebody who was a friend of mine, and that's certainly a big challenge. So our talk today is entitled When Life Changes in an Instant, because when you sit a person down and you give them the diagnosis of ALS, it truly feels as though their life has changed in that instant. But it's a disease that just keeps on changing, and in the past week I had a woman express to me a wonderful analogy of describing herself feeling like she is enveloped in bubble wrap, and every week somebody's just punching a bubble and breaking a bubble so that she's feeling the progression over time as she's losing her bubbles. So today we're just going to review what ALS is, who it affects. We're going to talk about symptoms and causes, and then we're going to talk about how to treat and manage our folks over time. Everybody knows that the other name for amyotrophic lateral sclerosis is Lou Gehrig's disease. And there's a picture of Lou Gehrig up on the screen here. He was the New York Yankees player who succumbed to ALS in his 30s after a very short but successful career in baseball. Depicted on the right side of the screen, you will see the motor neuron attached to the muscle. On the left side is what's a healthy nerve and muscle relationship, and that's what all of us have. On the right is what happens to people with ALS. When the motor neurons get affected and they don't get enough oxygen and nutrients, they become atrophied, they shrivel, and weakness occurs.
Cindy, I'm just going to, I realized I shut off the volume because we were getting interference from them, so I'm going to put them back on to tell them they have to be quiet. So for those of you who are attending at GoToMeeting, you might have had a mute momentarily. For those of you who are listening, you can't speak because your feedback comes through the telephone, okay? Hello? Well, it could be that they thought they all got disconnected, so we'll see what happens. All right. Thank you.
So ALS is actually a syndrome characterized by a number of different symptoms. The most prominent will be muscle weakness and muscle atrophy. They can develop spasticity, and some people that can be quite profound, and hyperreflexia, or real jumpy reflexes, not only of the deep tendon reflexes when you think of somebody doing a knee jerk, but also of their emotions. They can have exaggerated emotions as well. This is due to the motor neurons, which I showed you in the previous slide, in the cortex, in the midbrain, and in the spinal cord being affected. Generally, it's thought to be a rapidly progressive disease, and it is a degenerative disease. It was first described in 1874 by a French neurologist, Jean-Marie Charcot, and in the ensuing of almost 150 years, we certainly have learned a lot about it, but we have not really made huge strides in terms of cures for it. However, there are a number of things that we can do to help treat it, and we'll talk about that later.
So I'm going to talk a little bit about how ALS may present in some of our patients. It can present as muscular atrophy or weakness in the legs and arms that's usually asymmetrical, meaning that it's one side or the other. Often the first symptom in folks is maybe a weak hand, a dropped foot, things like that, and you know, that makes, I mean, there's a lot of diseases that can cause things like that, so it makes the diagnosis of this challenging. We also have patients that can present with the bulbar symptoms, loss of speech and swallowing. You know, it's not uncommon for us to hear, you know, when people first have their symptoms that, you know, I was at work and I started to have these changes in speech and people thought I was coming to work drunk. So that's a lot, sometimes what folks go through. And then you can have a mixed bulbar Amyotrophic presentation. So there's variants of ALS. ALS, by classic definition, is people that have both upper motor neurons. There's upper motor neurons that are involved in the brain, and then there's lower motor neurons that are at the level of spinal cord and below. So true ALS has both upper motor neuron signs and lower motor neuron signs. But there's variants, and we see patients also with primary lateral sclerosis, which is only upper motor neuron involvement. We have people that have progressive bulbar palsy, which is only speech and swallowing involvement. And then we have people with progressive muscular atrophy that their speech and swallowing parts are just fine, but they have all this profound weakness. The incidence is, the last I looked, 2 to 3 per 100,000 incidents, 5 times higher than Huntington's, and about equal to the incidence of multiple sclerosis. There's about 16,000 people living with ALS in the United States, and approximately 5,600 Americans are diagnosed with ALS each year. Now there are more people with MS just because MS is a longer course of disease. So the incidence is the same for both disease, and both are devastating, but folks with ALS don't survive as long as folks with MS. ALS is slightly more prevalent in men than women, and the usual age of onset is in the 5th to 7th decade, but it does occur in younger and older people. In the time that I've been at the clinic, the youngest person that we've been diagnosed has been in their early 20s. We certainly have had folks in their 80s and 90s that have been diagnosed, but the typical is in that 5th to 7th decade. The average survival from diagnosis is 2 to 5 years, but some patients live longer and some patients certainly progress more quickly. You know, I took care of a gentleman a couple of years ago who, from date of diagnosis, although he may have had symptoms a little bit before, but from date of diagnosis to the date he died was less than a year. We have folks in our practice that we've been following 10 plus years with the disease. And the usual cause of death is from respiratory failure.
So what symptoms can people...
Can I just ask a question about the disease trajectory? So does age have any implications in terms of how long someone is likely to live with a disease? So if I'm in my 7th decade, am I likely to have a shorter prognosis than someone who's in 40?
It makes a difference somewhat in how the person presents. People that have the bulbar onset tend to have a much more rapid progression because it affects key things, swallowing, and that usually affects breathing muscles as well. Folks that have the lower motor neuron presentation tend to have a little bit longer, and it also depends on choices that people make as far as interventions that they want to have to support, you know, difficulties breathing, difficulties swallowing, and we'll talk about some of that later.
I also recently read that people who have a lot of spasticity can have a quicker time course as well. So in terms of symptoms, the most obvious are going to be the muscle weakness and the muscle wasting. And people generally, if they come in and their arm is affected or their leg is affected, they'll say, well, what's going to happen to me next? And we cannot be sure which path the weakness is going to take, and that's one of the frustrations, is you really can't tell somebody, well, here's what you can expect next, because you don't know where the weakness is going. But if they have weakness in one limb, it generally goes to the other limb, and if it's, you know, starting in the uppers, it usually goes uppers before it goes lowers, but it's hard to really predict with any certainty. And then the slurring of speech, as Deb mentioned, can be particularly troublesome for people, and trying to plan before they lose their ability to communicate verbally is critical.
I had a patient who passed away a couple of years ago who described, and Cindy and I both helped facilitate a support group, and she described, you know, when she was losing her speech and losing her ability to do things, she said, I feel like I'm disappearing. I feel like, you know, I'm surrounded by friends and family, but I feel like I'm not, you know, be able to engage with them, and I feel like I'm disappearing from their lives.
Yeah, oftentimes people will still try and speak long after they're intelligible with their speech, and I find that the people who are losing their ability to speak have the most to say. So they want to talk to you, and they'll talk fast, and you really have to just slow them down and try and say, you know, one word at a time or a couple words at a time, because it's very hard. But I think most of them tend to be the older women who aren't into the technology, and they're either right or they'll just go, and they'll talk away, and you're like, that's nice, but I need you to go back and go word by word, because it's very hard to understand them.
And I think it's important that as someone's losing their speech, that you find out how they're communicating and allow them to communicate. And I always ask folks, when they're coming in to a visit with me, if they're okay, if they start a phrase, are you okay with somebody finishing that, or do you want to get it all out? And you really have to plan for extra time with them. You know, some people are fine, you know, they want to get what they want said, and they'll say, okay, if I start it, you can finish it. But some people, that really irks them.
Yeah, it's hard for these folks to be in any social situation, because if you think of even when, you know, we're just past the Christmas holidays, when you get together with everybody and you have lots of people and everyone's talking at once, well, if you're an ALS patient and it's literally taking you 30 seconds to get out a word, how much more has gone on in the conversation? So by the time they get what they want, that topic is already gone. So it's really a struggle for them as they're trying to stay engaged and be part of what's going on around them. As Deb mentioned, the bulbar symptoms, which you kind of think is the neck area, are really the critical parts. So swallowing and breathing tend to go hand in hand. There's a, you know, speech therapy, I think, is here, and that's a critical need for people, is to keep safe swallowing. They will try and tell us how safe their swallowing is, even when we know it isn't, and we try and transition them to feeding tubes as is appropriate, but we tell them, based on what the speech therapist allows, they can still eat orally, but it's good to try and get a feeding tube in sooner rather than later, because when they have difficulty breathing, they're not going to be safe to have a PEG tube if, you know, their breathing is compromised before their swallowing is. And the breathing in people with neuromuscular disease is certainly difficult in a sitting position, but it's even more challenging in a lying down position. If we're all sitting here, we have gravity helping to move our diaphragm down, and what happens in ALS folks is that their lung tissue is good, it's just the supportive muscles can't help blow off the carbon dioxide, so they get CO2 retention. And they can compromise somewhat when they're sitting, but if you lay them down, you lose the ability of gravity to help, and that's when their symptoms are going to show up. So we're always looking to see how sleepy they are during the day, are they getting headaches when they wake up in the morning, and those kinds of things. And then muscle twitching or fasciculations is usually seen early on in the disease, before the muscle weakness and wasting. The muscles, as they're dying, if you think back to that first picture that I showed, as the motor neurons are getting damaged and the muscles are atrophying, that's when they get the fasciculations. They may still have pretty good weakness, but you know, it's not a painful thing, it's just kind of an annoying sort of thing. For some people they can be really bothered, but that's really signaling a progression of weakness. As Deb mentioned, we diagnose people based on upper motor neuron symptoms and lower motor neuron symptoms. So focusing on the upper, that's more the spasticity, the muscle tightness, the exaggerated reflexes, and you can also have muscle weakness as part of upper motor neuron symptoms. And then the lower motor neuron symptoms are typically the muscle weakness and wasting. Our folks can get a lot of muscle cramps, and that can be very uncomfortable for them. We've already mentioned the twitching.
So what everyone wants to know when they come is what caused this. And, I mean, the last line says it all, bottom line is we don't know. There's a lot of research in this area as to what the causative factor is. Neurotoxins may play a role. It may be environmental. There's a thought that it may be non-surgical traumatic injuries. There's a lot of football players that are, you know, professional sports players that develop ALS. Going back to environmental, there's a lot of our veterans that have developed ALS, and the VA has really stepped up and is really supporting these folks and looking into this, and they have a registry looking at this. It may be an immunological deficit, an inflammatory process, and then about 5 to 10% are thought to be genetic.
I just want to say that the registry that Deb just mentioned is not only for the VA, but there is an ALS registry that's open to all the whole population of ALS, and we try and encourage our folks to tap in because, you know, Deb gave you what the incidence is, but we think that's a very low number, and it's just because there's no good way of capturing how many people are out there, so the registry is one way of doing it.
We probably follow 50 to 60 at a time.
It could be up to 70 too. But we have a wide catchment area, it's not just Rochester.
And sometimes we'll see someone as a second opinion. We see folks from not only the Rochester and surrounding counties, but we see folks from, you know, Binghamton, northern Pennsylvania, Buffalo, Syracuse. And so folks may come to us for a second opinion, and then, you know, we confirm the diagnosis and they go back and get their care locally. Talking a little bit more about the genetic causes, folks when they come in and see us always want to know, is this something that we could, you know, is genetic, is it possible that I'm going to pass this on to family members? So most cases are sporadic, 95% have no genetic link. And then about 5 to 10% of the cases are inherited, and it's usually very clear when it's inherited that it's several generations before that they've had family members that have had ALS. There is the first mutation that was identified and was the first one that was able to be tested for was the SOD1 mutation, and that only counts for about 20. So you have 5 to 10% of cases are inherited, and only 20% of those have this mutation. And there's the FUS gene and the ubiquitinin-2 mutation, and a whole laundry list more. They're coming up with more genes through research that may play a role in the inherited cases. And Cindy deals a lot with our genetic cases. I don't know how many are testable for commercially now.
We tend not to do a lot of genetic testing. As Deb said, it's pretty obvious when someone's going to have an inherited pattern because it's generally dominant, which means that if you roll the dice, it's sort of 50-50 whether someone's going to get it or not within their family. So it's not like it skips a generation usually. So they will come saying, oh yeah, my father had it, or my aunt had it, or I had cousins, or my grandparents.
But it's not like some other genetically inherited disease. There's not complete penetrance of the mutation, so you may have the mutation but not develop the disease as well. So there's a lot of variables, but we don't do a whole bunch of testing for familial, and we don't have a whole ton of our patients are familial, handful.
I think it's safe to say that there's still a lot that we have yet to learn about the genetics of ALS.
And then the progression, as we've kind of spoken to before, it varies from person to person. We can't sit in the office with someone and say this is what's going to happen. We can have folks that have a very slow, steady, stepwise progression. We have patients that have a very rapid progression. As I alluded to before, we had someone that from diagnosis to death was less than a year. And then we have folks that kind of have these declines and then they'll plateau for a while. And as I spoke about before, patients who start with the speech and swallowing or breathing problems progress more quickly.
The other thing which I have just noticed in my own practice is in terms of how long we'll survive, and I think that the chaplain comes into play here, is really what's their mindset and what's their will to live. We've had people that have surprised us that we have put on hospice, and they were on hospice for well over a year, and we just shake our heads going, we don't know how. And you have other people who are still walking maybe, or still fairly active, and they die in rapid course, and there's really no way that we can predict with any certainty. But I said earlier I was glad to see lots of people from therapies and all different disciplines, because it's really a team that cares for our ALS folks, and I always tell them it's a matter of addition, not subtraction. So they'll start with our clinic team, and then we add people. They never lose people. So the PAL is our center of care, and in the clinic, it's Deb and I and the physicians. We work with 10 different physicians who can take care of these folks. The speech therapist we have physical therapy and respiratory therapy who comes to our clinic. We tap into outpatient physical therapy. Home care is a tremendous resource, and I just want to say Deb and I are always willing to take calls, and we really appreciate you calling and letting us know what your needs are and what's going on, because that's the only way we can really do our best for folks. I was talking to a physical therapist from another agency yesterday, telling her what some of the resources are, and that was allowing her to do her job better. We are a muscular dystrophy association supported clinic, so we have an MTA representative who's there, and they are a tremendous support. One of the things that they do for our folks is hold a support group, and actually this week we're having our support group. It's once a month for not only the patients and their families, but anybody's welcome. So if anybody here had an interest in coming to our support group, it's really very open.
And I want to say too that we've had, I recognize some faces here, we've had staff members that have come to the clinic visits with the patients when there have been a lot of issues, and it helps for everybody to get at the table, and we welcome that. And every one of our physicians that see ALS patients will do home visits, so we often can link at home if that's what's best for the patient, and go out and all meet together. So I want to extend that invitation as well.
Absolutely. Okay, so there's no cure at this point for ALS. Even though we've known about it for over almost 150 years, we still haven't figured out how to stop it. There is one treatment It's Rilutec or Riluzole, which was FDA approved, and I've lost track of how long we've had that, but it was somewhere in the 1990s. It helps to slow the progression by about 2 to 3 months. It doesn't change the course of the disease, and it's certainly modest in its effect, but we do encourage people to start on treatment. The thought is that if they can start early in the course, that it may offer them greater benefit as opposed to if they're coming to us later in the game. Usually it's well tolerated. We have to monitor liver function tests, and occasionally have to take somebody off because their liver enzymes will spike, and it's usually for about the first 6 months, just to make sure they're not going to develop any toxicity there. There are quite a few things that are being tried. We just got word from one of our patients within the past couple of weeks. He was in a study in Syracuse for dexamethasone, I think is how it's pronounced. That was one of the clinical trials, and they stopped the trial because it was determined that it was not effective. So there's lots that's being tried, but again, we haven't come up with the right answer. So we're thinking that when we do have a way of slowing the progression more effectively, it's going to be really a cocktail. So you're going to be looking at a combination, much like you think of the HIV treatments. It's not one drug, but it's a combination of drugs. And short of that, that's why all the supportive care, all the therapies that are here, and nursing and chaplain, we all just need to work together to support them as best we can.
I'm going to talk a little bit about the symptomatic treatments that we offer folks. As Cindy had said before, muscle cramping can be very problematic for our folks, and we start kind of stepwise with these different medications and try to maximize. We push them to the ceiling of the dose before either stopping if it doesn't work or adding another one. Baclofen is a favorite go-to. We use Xanaflex, Valium, gabapentin, and Neurontin, and then we've had a couple of folks that have had a baclofen pump. You know, our folks that have a lot of spasticity, it can be a really tough nut to crack, and we, you know, I'm sad to say that we're not often very successful. So we use these medications along with stretching regimes as well. Excess saliva is also one of our tougher nuts to crack for folks. This can be very problematic for our bulbar patients. And it's not that the patients with ALS produce more saliva, it's they can't manage the secretions that they have. And you know, one of our doctors, one of his favorite things to say, or one of his go-to things to say is when we're in talking with someone, is that every person makes about 2 quarts of saliva a day, and when you can't swallow it, it's a big problem. So we use medications, and again, it's a balancing act with these. You know, you don't want to dry out too much, you don't want to have side effects, so we play around with these a lot, and we use amitriptyline, glycopyrrolate, we use atropine eye drops, scopolamine, transdermal patches. Botox and radiation are also FDA approved for excess saliva in these patients. I've had 2 patients that have had radiation to the salivary glands, and I don't think that in either case it was a real home run for them, but it is something that we can offer to them. And then, you know, we have patients that just, you know, it's frustrating, and I feel bad for them that they walk around with like a rolled up washcloth in their mouth, or, you know, bibs, and it's, you know, it can be very demeaning and a big hit to their self-esteem. It's tough socially when they're drooling. Cindy talked about some of these upper motor neuron symptoms, the excessive crying or laughing. It's part of the disease. These people can't control this. They may, you know, just kind of at the drop of the hat go into like hysterics of crying. It can be very socially problematic for them. There is a medication that's been FDA approved called Neurodex. It's a combination of 2 very common drugs, glifenicin, which is in cough syrup, and quinidine. It's expensive. The pharmacy at Strong will
No,
They won't anymore?
no, it's now FDA approved.
So they won't. They used to compound it for us before it was FDA approved and we could get around the cost, but now that it is, so,
I tried.
yeah. We use amitriptyline now as well, so.
How, no, they don't usually, oh, it's quinine, not
The other thing I just want to mention is that it's not only that their emotions may be exaggerated, but they sometimes may be inappropriate. You know, if someone is told that, oh, you know, your grandfather just died, they may laugh. They may have the wrong emotion coming out, and that certainly can be troubling for people in a social situation.
Pain is something else that we also deal with in our ALS patients, although ALS itself is not a painful disease. There can be pain associated with the things that occur because of the disease, the immobility, the stiffness. And we, you know, again, we use the things that are in everybody's toolbox, the NSAIDs, the non-narcotic pain medications, and then move on to narcotic pain medications for them. Positioning. Pillows are our best friend. And then anxiety and depression, you know, it's perfectly natural for these folks to have both of these. And we treat them with the normal medications that you use for these, and we wanna, I think this is often undertreated in our folks.
I was going to say, our folks will not admit to being depressed, so it certainly would be understandable that they are, but, you know, I feel like most of the times I have to coax them in some way to try and take medication to help with the mood. Okay, home care issues, which is where everybody here comes in. Physical therapy for mobility. We usually try and do home safety evals, just to make sure that the house is set up in a way that's going to be most meaningful for them. And as they lose progression, making sure that the person knows how to safely transfer, and that their family and friends know how to transfer them without injury. And then getting whatever equipment is needed in terms of power chairs, sliding boards, and things like that. And I need to mention to the physical therapist here, please be aware, because we are an MDA-sponsored clinic, we do have an MDA loan closet, so that our folks, if they can't afford through insurance to get any particular device, we need to work with our MDA representative to get them something. And I just had this happen last week. One of our folks lost their ability to transfer, and although it comes down gradually, it's amazing the level of denial, so that they think that they're compensating, but suddenly that one day they just can't do it anymore, and they thought, oh my gosh, it's happening all at once, and it really isn't. But their ability to see it and to identify it is the key issue.
And I want to add also, when thinking about equipment, we always try to bring in, we have a physical therapist, actually two that come to our clinic, and they love to talk with the community therapist, but you really have to do a lot of planning with these folks, because this is a disease that changes and we don't know the rate that it changes, and healthcare dollars and insurance dollars are precious, so we really need to be thoughtful and mindful in what we order for these folks, in making sure that they make good choices and use their insurance dollars wisely. You kind of have to think 2 or 3 steps ahead of the game when ordering equipment for them.
And this one case that I had, when she couldn't transfer, the physical therapist brought in a Ceralift for her, and of course it was crisis mode by that point, but the poor woman was not comfortable with that, and it created a lot of pain, so the next day the therapist had to think about a Hoyer transfer. So it's really trying to assess what the best need is for them. In terms of swallowing, we have speech therapy. We have Judith Kennedy, who works through our clinic. She has both a very strong personal identification with the disease as well as a professional. And we work with doing swallow evals, and then, you know, realize that any of our counterparts are willing to talk to you and share what they already know, but we appreciate everything that's being done in the home as well when questions continue. So we try and pitch the idea of a feeding tube, as I said, sooner rather than later, just because the compromised breathing can dictate when we can safely put a feeding tube in. The other issue is in terms of nutrition. there's actually a study going on right now trying to figure out what the best diet is for somebody with ALS. We don't know if it's higher protein, is it more carbohydrates, is it more fats, but to have them have a diet where they're not losing weight is really critical. So how can we get those calories in, and what's the the highest impact for the least amount of energy for them to use? So the high calorie shakes and all those kinds of things, or recipes for families to make, getting the consistency of the food with maximum calories, because we all go through our day and we snack and we have our meals and we don't think twice about it, but for ALS patients it becomes work. It becomes a job for them to have to think, I have to eat breakfast. Oh my goodness. Because what we can do in 5 or 10 minutes, they may take up to an hour to do, and people lose interest after that time. So we really have to get calories in quickly and effectively. Speech therapy, again, you can start out with sort of low-tech devices, and some of our folks have the high-tech gadgets. They'll have the dots on their glasses, and they can maneuver the computer and talk like that. But even that way, if they want to say, hi, how are you today? I'm doing fine, that can be a whole morning's work for them to write out that kind of sentence. So it's really a chore for people to communicate when they lose that vocalization. But something simple as letterboards can be helpful. If they're getting up in the middle of the night and they just want to say something quickly, that can be a go-to, because to try and get them up in their chair and set up in front of a computer and get them positioned isn't going to be practical. So always trying to figure out the easiest way for them to get their message out is really critical, because who doesn't want to be heard? Skin integrity we put down. On the whole, it's not really an issue. Occasionally, it can be, they don't lose their sensation, so they can still feel, but it's more of a position because of the weakness, and if they're not able to change, that's something just to keep in mind, and we appreciate nursing's good eyes on those. Usually it's more like skin tears and things that can happen.
But we do have some folks who are very uncomfortable in bed, and so they spend all their time either in a recliner or a chair, and we've run into some pretty nasty breakdowns. So, and a lot of it is they feel comfortable and in control in certain positions, and in a disease where you lose control of everything, it's
so breathing, we mentioned, is really what's going to determine their longevity. We start with the BiPAP because we call that our breathing booster. As I mentioned, it's not their lung tissue that's affected, it's their muscle. So with the BiPAP, as they start to take a breath, the machine can actually maximize that breath and give them the volume that they need to help blow off the CO2. Some people can tolerate it, some people can't tolerate it. If they can't tolerate it, then we sort of go the natural course and do whatever measures to provide comfort. And that may include oxygen, but again, if they have CO2 retention and you give them oxygen, that can actually shut off their respiratory drive. So you have to be thoughtful when you're trying to help relieve any of their breathing issues like shortness of breath. So medications like morphine are terrific for that. Making sure that they're in a position, as we talked about, if they're lying down, it's harder than if they're sitting up. And then you have the talk of, well, do you want to have a trach event? And what does that really mean? Because your whole life changes with the trach event. And right now is probably, throughout my career, this is the time that we've had the most people on ventilators, and it's usually the women who want to go on it. Or there's a culture, Hispanic people won't tell you what they want, but when it comes to the crisis, they're not going to want to say no. So those have been the folks that tend to go on the ventilators. And we probably have, I think, 3 people right now on home ventilators. Psychosocial issues are huge. Obviously, everybody knows that to go through a disease like this is not cheap. and insurance can play a role. Deb and I get questions every December, what insurance should I use? What do you think I should do? We're not insurance experts, but that becomes a real issue for people. Family issues, boy, you know, who has a functional family to begin with, and then you throw ALS on top of it. You know, I had a patient, my patient who went off her feet last week. The family is very loving and very supportive, but she was the oldest sibling. She was in control, and everybody looked to her to make decisions, and she just couldn't. She had a history of depression, and she was lying in bed 20 hours a day. And she just wasn't letting anybody else do things. And the physical therapist from home care was going, I can't believe this, I can't believe this. I said, but the family's there and the family is supportive. But until she went off her feet and could not move one bit, she wasn't ready to let other people in and help. So now we have moved a tremendous length in 1 week, but it was very difficult. I think mostly on the physical therapist from home care. So, you know, depression is huge. Fear, you know, Deb and I get the question, what's going to happen to me next? Who doesn't want to know what's going to happen? Who doesn't want to be able to plan? And this disease just doesn't allow it. And role changes, you know, if you have the husband who's used to having the wife do everything around the house, and the wife has ALS, oh my goodness. Or you have the husband who's used to taking care of all the finances and they can't even talk, oh my goodness, how are you going to get that spouse to do what they need? So huge life changes, a lot going on all at once.
Yeah, I had a patient who, when he was dying, you know, knew he was dying, and he, you know, they were in an okay place with that, and he was making a manual for his wife on how to take care of things in the house for when he was gone. You know, this is when you need to do this, and this is how you handle this. And it was I think it was beautiful for them to be able to go through that together. But,
I have a question about insurances. When you have a patient come in, you identify they're a veteran. If they're not already enrolled in VA care, do you refer them to VA?
We have a handbook that we give people, and it's a handbook that was made to give them resources locally, and that's one of the sections. It's one of the questions we ask. If you're a veteran, you know, my question is, do you have a primary care in the Veterans Administration? If they say no, I said, you go right from this office and you go get yourself one. Because once they have a primary care, they can get connected into the VA system, and the VA has been more than generous. It took them a long while to reach that point, but they have provided home care services, they provided equipment.
state-of-the-art equipment, things that's
State-of-the-art equipment. But having said that, sometimes the government gets in the way of itself. So we had one, this was sad, it was a woman who had come to clinic and then she was at home and she stopped coming to clinic and she wanted a cough assist. So the VA said, wonderful, and they dropped the cough assist off. What the VA didn't have was a respiratory therapist to show her how to use it or to get it set up with the pressures. So she's dying, and I'm getting a call from the VA going, yeah, she needs to know how to use it. Well, for, you know, liability, I can't send my respiratory therapist out to her for various reasons, and that was a black hole in the VA system. So we really have to work together, and that's where that whole team slide came in. You know, you're always adding people, but you have to make sure that they get all the information they need and not just equipment being drop shipped to them.
So have they fixed that hole now at the VA?
I don't know.
Hopefully, so the next person.
No, they have
comes
not.
along.
No, they
I
have
used to work there, so.
I don't believe so, but I think the people who are using the VA system right now are more engaged in our clinic. This was somebody who just sort of, and sometimes they do that. Some people will come once or twice. Some people don't believe what we have to tell them, so we won't see them for a year. You know, they're terrified to come to see us. So you really have to try and give them the message softly. And if you can do that and you keep them engaged in the clinic, it works better. But you know, every now and again you have someone who comes on a yearly basis, and then you're always scrambling.
I mean, we have folks that come that just, you know, their denial runs so deep and so strong, that, you know, there isn't any possible way I have this. And there are folks that tend to do a lot of doctor shopping. We have a patient right now that has been to every single major center up and down the East Coast and into the Midwest, and, you know, is looking for someone else to tell her this isn't what I have.
And will accept the odds diagnosis.
Yes.
Yeah, that's another big thing.
Yes.
But they will not take that ALS, yeah.
So we always try talking about what are their wishes and what are end-of-life thoughts for them, but as you can imagine, it's not something somebody comes jumping at the chance to talk about. I always try and pitch healthcare proxy because everybody over 18 should have one, and I hope everyone in this room has one. And it's really the gift you give not only yourself but your family, but moving them beyond that in terms of what are their wishes can be challenging. And of course, you're going to get people that wait until that crisis situation when they want to talk about it. You can't force them, but you certainly can bring it up. And you know, I've certainly appreciated all the work from the nurses and the staff from the home care agencies when I call and say, you know, we've really been trying to do this, but we need your help. And sometimes maybe in a home situation, it can be easier to talk to. Various ways of coping. We certainly have mentioned that it's a disease of loss. So they grieve, and they grieve not only with the diagnosis, but they grieve with every bubble that gets popped along the way, and just respecting that and giving them the opportunity to express that grief. And because it's a disease of loss, you have to try and give them control where they can. So my patient who stopped transferring last week, I sat down for over an hour with her brother, and I said, look, I appreciate that you're the younger brother and you defer to her, I said, but it's really a question of safety, and you can say, look, I don't have the choice, you no longer have the choice, it's not safe, but you give them the choices when you can. You just have to know what the limits are for them. And we try our best to anticipatory guide them, and again, they will come when they're ready. You can't force anybody to get there. The two huge groups that are advocates and supports for ALS patients, and if you haven't been there, please go to both the MDA and the ALS website. The ALS Association, or ELSA, is active in Rochester. They don't sponsor us, but again, they're available for our folks. They go every May down to Washington, D.C., and they lobby Congress. So they gather ALS folks, and they go and they talk to all the political people. They were the ones to get the registry open to all the ALS folks instead of just being for the VA. They also have a support group in Rochester. It's held separately from ours, and quite often patients will use both support groups, which I think is terrific. And then the MDA Association, which we're affiliated with, has the loan closet available. We have our support group. They certainly try and do awareness. May is ALS Awareness Month. They do fundraising for research, and there's a gala every year to raise monies to help MDA support research. And the local resources, Susan, our representative, is just tremendous in helping our folks. For people who are home and trying to put a home care plan together, or who want to sort of organize family and friends to help, the My Muscle Team website is a good one for them to do it. And there's also something called Patients Like Me, that if people go, they can connect to other folks with ALS. You always have to be a little savvy when you're on the website, because you know, you never know what you're getting when you're on the internet. And there's also a website called ALS Untangled, which is an interesting website because, as Deb said, we have people who go up and down the East Coast going, are you sure I don't have, are you sure I have this? Are you sure it isn't something else? So people will come and say, I'm sure I have Lyme disease. Or we have people going, I want to go to India for stem cell treatment. And you're just like, but, you know, you can't say no. Well, ALS Untangled is a website that is run by a physician out of Duke, and he's collected a number of other physicians. So when people say, I want to do things like this, they go and they research it. They don't want to say no to the patient, that's ridiculous, but they literally put a scholarly paper together, usually a couple pages, to say, look, here's what we've seen in our research, here's what we think is good, here's what we think you really ought to be concerned about, and here's our position on this topic. So there's a list of topics that they have evaluated, there's a longer list of topics that they have yet to evaluate, but that's an interesting site for people to go to as well. Clinical trials, clinicaltrials.gov is the national website. If anyone hasn't been there, it's a good website to go to, and we tell our people that they can look there to see what's going on throughout the world with research. But more locally, there's NEALS, the Northeast ALS Consortium. Syracuse and Cleveland are currently in that system. They have studies that are up and running in clinical trials, and as well as New York City. We're going to be joining them. We're in the process of getting our first clinical trial up and running this spring. So there are local options for people if they want to do research as well.
And then, you know, we've talked a little bit about this in planning for end of life with these folks, and again, that's a team approach, working with the families, the home care agencies, and us. You know, the healthcare proxy form, the MOLS form that we use at the hospital and in the community, and having the conversation about choices. You have to present all of the choices to the patient in an unbiased manner, and I tell people that anything they choose can be undone. I've been involved in a couple of cases where we've done home ventilator withdrawal at home. You know, so that's an option for folks as well. You know, our folks that choose to go on ventilators, they can choose to stop that, and we've been very successful in doing that at home in a very peaceful and meaningful way. You know, people that get their feeding tube can choose to stop using their feeding tube. People that go on BiPAP can choose to stop using their BiPAP. The Palliative Care and Information Act in 2011 kind of mandates all of us to offer palliative care to our folks. And then bringing hospice on board early.
And themes of hope. Our folks really have hope where it seems that there isn't much. I can tell you that these folks hope for a cure, and they hope for a cure to the day that they die. You know, it's not uncommon, even people with end stage going, so what's new? What's going on out there? They get hope through you and through us and through all the social supports that they have. Spiritual beliefs can be a center of hope for these folks. And there have been certainly studies and papers about this, and I think the pals who do the best are the ones who can adapt as those bubbles get popped, and they can sort of reframe how they live within their new set of limitations. That's easier when the course is slow. It's much harder when the course is happening pretty rapidly. Living in the moment has been a strategy that some people have found useful. I myself am still trying to practice that one, but you know, helping them find some peace. So there's hope until the end of life.
And I think that hope changes for folks. You know, at the end, they all hope for a peaceful passing, and that their families are going to be okay. And it's all of our jobs in this room to help make that happen. And give them the death that they want, where they want, how they want.
And just to finish up with resources for the Muscular Dystrophy Association and the ALS, which are the two critical pieces for them. The support groups, which both offer the internet, the good and the bad. You have to help them screen, and then the clinicaltrials.gov site is a good site.
We have, I think, a little time for questions. I want to thank all of you for coming. I want to thank all of you for all that you do. We can't do what we do without you in the community supporting these patients. I I think you all probably have the toughest job.
Yeah, being with them day to day, but truly when I said it's a matter of addition, not subtraction, we feel that you're part of us and we're part of you, and the only time we get mad when people, about phone calls is when people don't call and they really need to be, because Deb and I, that's, you know, we go and we look at who's calling, and the ALS are the ones that we get to first, so.
Yeah, there's nothing worse than, you know, we see our patients anywhere from, depending on how they're doing, it can be, we can see them monthly to, you know, we may see someone once a year, every 6 months. There's nothing worse than not hearing from someone and have them come with, you know, 5 pages of problems to clinic that, you know, a lot could be solved over the phone prior.
And also, our mission, as I'm sure is yours, is to keep the patients at home and to avoid that hospitalization. So how can we partner with you to have you come and do the home visit, or to help us avoid that crisis with the patients so that they don't have to go into the hospital?
Right, and our patients, I don't think, you know, I think most of our patients die at home, and I think it's hard for them to go somewhere because of the challenges with this disease. They're extremely weak, they can't communicate, and it just makes, the folks that I've had that have gone to a facility and died have not always had the best experience, because it's a whole new group of people taking care of them at the end.
I just have to say, one of the greatest moments of my career was getting a call from Deb. We had a gentleman who was still walking. He was bulbar, so his breathing was compromised. He couldn't talk verbally, and his swallowing was diminishing. And they didn't have, the family didn't have that talk yet. And the daughter was good enough to say, look, you know, the elephant's in the room. What do you want, Dad? And he was only in his late 50s. As I say, he was still walking and very functioning, and he said, I don't want this. This is not how I want to live. Deb calls me. It was my day off because I work part-time. And she said, Mr. So-and-so has just come into the hospital and he wants to go to palliative care and he wants you to come. So I was out of town, drove into Rochester. My husband kindly stopped the car. I went up to the palliative care and I felt like I was walking into, what is that, New Jersey? Sopranos. Because he was Italian. So his daughter and his wife, I'm like, oh, hi, because I greet them outside the room, and I walk in the room, and all of the Florida Italian family is surrounding him, and there he is, sitting on the bed, and I sat next to him, and he's like pointing to his intravenous with the morphine, and he's like, I got what I want. And that was the last time I saw him, and his daughter's like, but they say we can only stay here 2 weeks. I said, time out. I said, he will do what he needs to. It'll work out. And he peacefully passed within 48 hours and surprised everybody. There was no way one would have expected it, but that was what he wanted, and that was what they honored, and it was a tremendous moment, I think, for everybody.
With regard to your symptom management, do you guys recommend the acupuncture? Because there's some early studies out, and I've used it in patients for symptom management in ALS, and it has helped.
I certainly have no problem with people getting acupuncture if they bring it to us and that's something they want to try. I always tell them to go ahead and try it. You know, it's always making sure that there's no harm, and I don't see any harm in that one. Going to India for stem cells, I have a problem. Acupuncture, I don't.
Some of us on visiting nurse hospice team do work in the nursing home. Do you have any sense of, you said very few people end up in the nursing home. Is there any kind of advice you can give us to help support these people when they end up in one of our nursing homes? Should we contact you?
Absolutely.
Maybe some education for the nursing homes?
And we, both of us have gone out to nursing homes that have had ALS patients and met in a forum just like this, and we're happy to do that. Our doctors have made visits to the various nursing homes.
Yeah, as I say, it's addition, not subtraction. So even when somebody goes to a nursing home, we've done home visits to nursing homes, we've done education. The biggest problem that I've run across is that you have a nursing home mentality where they're used to people who come and they're static. They're not used to people who come and they're continuing to get worse, and the staff doesn't quite know what to do with it. So our patients want to maintain control, and the staff is saying, nope, this is how you do it because you're here. So trying to have us bridge that is usually where our greatest need is. But, yeah, our care for patients does not stop at our clinic.
And people have a risk for emotional, like, ability. Do they have a risk for dementia, or cognitive?
Yes, we didn't put that on the slide. We have, that's just come out in probably about the past 5 years, that there can be some frontal temporal lobe dementia. It tends to run more with the people who have the familial forms of ALS. There's not a consensus yet in terms of the best way to assess for it.
It's underdiagnosed, and undertreated, but it's recognized that this can happen. Sometimes yes, there can be a crossover, and that's being recognized. I had a patient who, she was just a lovely woman, and she had familial ALS, and she was getting violent at home. Her husband had to turn off the power to her wheelchair because she was like, ramming family members with the wheelchair. It's like, she's dangerous with this.
Yeah, we had somebody who actually was diagnosed with dementia, and then they said, oh, wait, the muscles aren't working quite right. So the ALS never really got to be a huge issue for him, but the dementia did. So he went into a nursing home and did a pretty short course. But I think there's it's almost 150 years, and there's still a lot that we just don't know. But that's a great question.
Right, and I think that we have to figure out how to recognize this better, because it has implications for people being able to make decisions, and are they capable of making decisions moving forward.
I just have a question. Our patients with ALS have the muscle weakness, and those limbs always seem to get very swollen. Is there any way to help with that other than their range of motion that we do with them?
Elevation and range of motion, and it's just because, when you have muscles that don't work, your body relies on the muscles to push things back to the heart, so they get this dependent edema. Kind of one thing that has been recognized recently, and Cindy and I were just at a conference a couple of months ago, is that the time frame when people first go off their feet, they're at increased risk for developing blood clot and pulmonary embolism. Mm-hmm. So the folks in the community and us need to recognize that as a risk. We don't put people on prophylaxis because also with this disease they're at great risk to fall. So not a whole lot you can do about it, but know that the risk is there kind of in that time frame when they first go off their feet.
So physical and occupational therapy are wonderful to pull in because they can help. OT's always been good with, massaging, or do they need any gloves or any other devices to help with the swelling, and certainly PT, making sure that range of motion is properly taught and that gets carried through with the family. Sometimes people think therapy does it, but therapy's teaching so that the family can do, and it's making sure that they follow through with that.
And using some of these, fancy wheelchairs that have the tilt and recline, the elevating leg rests are key for these folks so that they can put their feet up. But, you could lead a horse to water. Some people don't want to use that function. So.
Right, like my current patient was recliner bound, get in the wheelchair very little, and now is completely bed bound, doesn't even get out of bed. And he's just edematous in all of his limbs. And we do range of motion with him. I just didn't know if there was anything else we could do to help with that.
Probably more extreme of a case than typical.
Thank you both very much.
Yes,
This was
Thank you for
tremendous.
having us.